Okay, can everybody see the screen now? Modise, can you see your slides?
Yes, I can see the screen now.
Okay, so you just carry on talking and then you just tell me when you want me to forward the slide, okay?
Okay.
Okay.
Good evening, everybody. Apologies for being a bit late. I think we've got a challenge with the computer here network. Greatly apologize for the delay. Our topic today is quite a diverse topic. We'll be discussing infectious colitis. Next slide.
Next slide, Jill. There.
Yeah, okay.
This topic it's quite a diverse topic, as I mentioned, that we'll be mainly concentrating on the major important ones like your Clostridioides colitis, the Mycobacterium, and lastly the parasitic colitis, the Amoebic colitis. Firstly, one important topic that we discuss is Clostridium difficile. We know that quite a lot of our patients, particularly in our setting, in IBD communities, been infected. They get infected with Clostridium difficile because of the overgrowth of this normal commensal in our GIT, because of this between normal commensal and the gut. So these are one of few risk factors for the patients to that facilitate the overgrowth of these Clostridium difficile. One of the major risk factors is basically the antibiotic treatment that we know, in particular the penicillin and fluoroquinolones also been implicated, but basically almost every antibiotics has been implicated in causality of this Clostridium difficile colitis. And most important, people who are setting the IBD that may predispose patients to pseudomembranous colitis, the people who have been hospitalized for a longer stay, and people who reside in nursing home. At times, there are no identified risk factors, and we do find this in a community where there is no identified risk factor. We call it community-acquired Clostridium difficile. People of the age more than 65 years are predisposed to Clostridium infections and overgrowth, and people with poor immune system.
Okay, so just a few
Next
comments
slide.
there. First of all, the name has changed. It's no longer Clostridium, it's Clostridioides. So that's the new name of the organism. And just to mention, it's not synonymous with pseudomembranous colitis. Pseudomembranous colitis is a macroscopic feature that you see at endoscopy with pseudomembranes, and it's not synonymous with C. diff. There's lots of other infectious causes of pseudomembranous colitis. Okay, so your next slide.
Yes, thanks, Prof. As I mentioned that the Clostridium infection can actually even occur even after 1 or 2 days after starting antibiotics, or sometimes can happen months, even longer after finishing the course of the antibiotics. The real pathogenesis is that the antibiotics basically upsets the natural health balance between the gut bacteria, that therefore leading to overgrowth of the Clostridium difficile. The number of patients presenting with clostridial infections have actually seen in the last few years increasing in the last 10 years, because there's quite a number of large population of people using a lot of antibiotics, and the mortality rate in these patients is sitting around 7%. It's one of these causes of, as Prof mentioned, the pseudomembranous colitis, because it produces the toxins like from the Clostridium, but also the normal flora. The common antibiotics that we've mentioned is cephalosporin, carbapenems, and fluoroquinins, and the Bactrim and beta-lactam. But any antibiotics, as I mentioned previously, can actually trigger the disease. So in an IBD community, every patient who comes with a flare, especially on immunosuppressant, these patients need to be screened for Clostridium difficile. To mention that IBD on its own, it's an independent risk factor for development of Clostridium difficile, even without traditional risk factors like antibiotics. So there's almost more than 5 times patients with IBD likely to develop Clostridium difficile infection than any patient without inflammatory bowel disease. Next slide, please. In patients with IBD, it's not necessarily associated with the use of 5-ASA and immunosuppressant, but the steroids and biologic have always been associated with increased risk of this type of infection. And once somebody is infected with Clostridium infection, there's high risk of long hospitalization, and the mortality rate increases, and the increased readmission rates. And one of the dreaded things in IBD is the increased long-term colectomy risk in these patients. So how do you do a CDI screening in this patient? We need to collect the toxigenic stool in someone who present with diarrhea in a correct setting. These are the tests that you do, highly sensitive tests. We look at the glutamate dehydrogenase or a nucleic acid amplification test. This test not really highly, it has low specificity, so it detects the organism, but not necessarily detect an organism that is producing the toxin. The one that we normally use that is more specific is your the toxin A and B enzyme immunoassay. This way you identify toxin in the in the stools, and it's quite highly sensitive on this patient. But the gold standard is your cytotoxin neutralizing assay, which has been found that it's actually much better in detecting the Clostridium difficile toxin. To mention that endoscopy is not recommended as a diagnostic tool, as pseudomembranous membrane is only found in a small percentage, 13% of patients hospitalized with a C. diff infection. Next slide, please.
So what is the problem with the toxin test, the immunoassay for the toxin test? Do you know of any issue with that?
It does not necessarily identify Clostridium that is producing toxins. It's not specific for that.
Well, it's a toxin test, so it's to check for toxins. Okay, so the problem with that test is it's actually got quite a low sensitivity. The reason being is that you have to have quite a reasonable amount of toxin for it to actually detect it. So you can get false negatives with that test. All right, carry on.
These are some of the complications of patients presenting with Clostridium difficile toxins. Commonly, because of severe diarrhea, they present with dehydration leading to renal failure, toxic megacolon, which can complicate and with peritonitis, with bowel perforation. And interestingly is that even after treatment with Clostridium, anti-Clostridium treatment, these patients can actually, the infection can recur days or weeks, even what apparently has been cleared, the infection. So there's high recurrence rates. So even if after 2 months you've treated the patient for C. diff, the patient can still come back with the recurrence of the Clostridium difficile. Next slide.
And recurrent C. diff, what is the percentage of people that will have a recurrence?
I think probably mentioned around 20% of patients.
Okay, carry on.
How do you prevent the Clostridium difficile infection? It's very important that we must have a strict infection control guidelines, like hand washing before and after treating each and every patient with soap or alcohol sanitizer, because this Clostridium is actually a spore-forming organism that a lot of the spores could be sitting around it, so it could be very difficult or it's very easy to transfer one spore from one patient to another. Also important for contact precautions, patient with Clostridium infection must be kept in a private room and must wear disposable gloves when you're treating this patient, also the patient. And even after the diarrhea has ended, the patient is advised that we should be isolated for another 48 hours. Over and above, the most important thing is we need to avoid unnecessary use of antibiotics. The antibiotics must be used judiciously to make sure only patients that need those antibiotics. In terms of general treatment, in patients moderate to severe, oral vancomycin 125 milligrams 6 hourly has been found to be effective. But in complicated cases, the combination of both oral vancomycin and IV metronidazole has been found to be much more effective in preventing the morbidity and mortality in these patients with C. diff infections. Next.
So just a point here that alcohol doesn't work in killing the spores. So you have to use soap and water. Alcohol disinfectants are pretty useless in this setting. In terms of treatment, how would you define a non-severe and a severe attack of C. diff infection? What are the sort of things that
if somebody comes with severe, like fever, blood diarrhea, would be very, very worried. And in severe cases, somebody with toxic megacolon, somebody had diarrhea, suddenly the diarrhea stops and then the patient's got abdominal pain and more like constipation. Like, you need to be worried that this most likely be complicated with Clostridium difficile. It's much more severe and complicated. And obviously, a patient presenting with renal failure, I would be very worried about this. That's most likely this is a complicated C. diff.
Okay, all right. You have mentioned oral vancomycin, but you haven't mentioned a drug that is actually probably better.
The metronidazole, it's not really. I thought vancomycin is the most important. Oral vancomycin is better than
Daxomycin. Okay, it's another drug that is very useful. Okay, so there's some excellent American infectious diseases guidelines which were published in 2021 recommending how you treat mild, moderate, severe, complicated C. diff. So perhaps you should take a look at those. All right, carry on.
Our next patients, the next topic is your Mycobacterium colitis. In our setting, especially in South Africa, we know that we got the prevalence and incidence of diabetes of TB is quite high. So it's one of the, especially with HIV in our community, we've got to be very cautious about missing patients with TB colitis. Actually, third commonest manifestation in the extrapulmonary side after the TB, after lymphadenopathy. It accounts for 12.8%. It's much more common amongst the AIDS patients. It may coexist in patients with IBD, or at times might mimic Crohn's disease because of the involvement of the TB in the GIT, where it involved the terminal ileum and cecum with granuloma and with central caseation with TB bacilli seen on tissue histology. That's the difference with the Crohn's disease, because we know that the Crohn's disease tend to affect the terminal ileum and the right side of the colon. It would normally present with patients present with abdominal pain, chronic diarrhea with constitutional symptoms of weight loss, fever, and pallor. And most important, the patient can have PR bleeding. How do you diagnose these patients? Look at the intestinal fluid PCR testing for AFB. It can be, you can also send it for a anti-acid fast bacilli. Skin test in our setting is a bit controversial. You can look at patient doing a chest X-ray. If you see fibrotic change in cavitator changes, and this patient could be suspected to be having also concomitant TB colitis. Abdominal X-ray, looking at prominent large bowel, especially on the right side, that will be suspicious. This most likely this patient could have TB. When you go on to do CT abdomen and pelvis, you would note the thickening of the colonic wall, especially as I mentioned, in the terminal ileum or ileocecal mass can be seen. On endoscopy, it's non-specific, but the ulceration can still be found from the rectum up to the ileocecal valve. That makes also diagnosis distinction between Mycobacterium colitis and ulcer and inflammatory bowel disease a bit difficult in the setting.
Thanks, Mash. I see you answered the question for Taxomycin. Okay. All right. So just a couple of things about TB. It is the major differential diagnosis of Crohn's disease in South Africa because it is almost indistinguishable. Affects the cecum and the terminal ileum. Unfortunately, the diagnosis, to make it 100% certain, you have to have either acid-fast bacilli, a positive TB culture, or caseating granulomas on your tissue biopsies. And less than a third of patients will actually have any of those. So you have to, it's a bit of a clinical conundrum. You have to look at the clinical situation, you have to look at biochemical, endoscopic, radiographic features, and sort of the things that would make you think that it might be intestinal TB. Clinically are fevers, night sweats, positive TB contact, very important. Weight loss can occur with Crohn's or TB, so that's not too helpful. Perianal disease is strongly predictive of Crohn's if that's present. Unfortunately, the duration of symptoms don't seem to make very much of a difference. You can have intestinal TB chronically. Okay. Biochemically, well, unfortunately, tuberculin skin test is not a test for active tuberculosis. It's a test for latent tuberculosis. Similarly, the IGRAs are not a test for active tuberculosis. Obviously, if you have a chest X-ray which shows features of active TB or previous TB, that's going to really make you think that you might be dealing with tuberculosis. And then on cross-sectional imaging, you often see quite severe involvement of the cecum with TB, worse than the terminal ileum. And at endoscopy, there are some features. It's also, again, not seen in every case, but circumferential ulcers and a really severely damaged ileocecal valve make you think of TB. But unfortunately, in this situation, we're very often forced to give patients a trial of TB therapy because that is how hard it is to make the diagnosis. And if the patients respond, we will then give a full course of TB treatment. If they don't respond, one needs to think whether you've missed Crohn's disease, and in that case, you would need to probably perform imaging again or to do endoscopy again to see if there's been any objective improvement. Does anybody have any questions about the TB story?
Hi, Prof. It's Gert van Merwe here from we recently had a discussion. Sorry, I'm in colorectal surgery, so please excuse my ignorance.
No, not at all.
So we recently had a discussion on the colorectal forum about likelihood of a patient having intestinal TB in the absence of evidence of active pulmonary TB, with the thinking being that, you know, intestinal TB most likely would result from swallowing TB bacills on expectoration of these bacills with pulmonary disease. So to what extent does pulmonary disease or lack of pulmonary disease exclude intestinal TB?
Okay, it doesn't, unfortunately. So 50% of patients who have intestinal tuberculosis will have a normal chest X-ray and no previous features of TB, so 100% normal chest X-ray. But a chest X-ray is not always the best way to pick up TB. So my colleague Vanita Gujja from India, who's probably the world's leading expert on this particular subject, she was very fortunately a SAGE's visitor just 2 months ago, and he routinely does a CT chest of all of his patients if he's considering that there might be intestinal tuberculosis. And if that is clear, then he feels a lot more strongly that TB could be ruled out.
Thanks, Prof.
Okay. Other questions? I'm trying to see the. Okay, so VG's just asked that role of HRCT, absolutely, and we know the tree and bud appearance is quite typical for TB. So if that's what you're seeing, you're going to be worried. And of course, a very low threshold to get our respiratory specialists to do bronchoscopy if you are concerned. And how common are strictures in intestinal TB? Yes, unfortunately, they do happen. Often, and there's not a great deal of evidence to support this, but certainly anecdotally, when TB heals, it strictures. So, it's often a sequelae of the tuberculosis and treatment of the TB as opposed to the TB itself. Okay, any other questions before we move on to our next topic? Oh, it's not going on. Okay, go for it, Modise.
Our next topic is CMV colitis. We know that CMV is one of the DNA herpes viruses, and that normally would infect, in terms of prevalence, we're sitting around 66% of prevalence in developed countries. But in our setting, in a developing country, we're sitting at this more than 90% of our people have got previous serocovalence of a CMV. Generally, in somebody who's immunocompetent, it gives you a mild infection, mild symptoms, and once the infections recede, the CMV virus just become latent in various tissues, like in most of our endothelial cells and macrophages and monocytes. But when the states that reactivate the CMV virus, like in somebody who's on immunosuppressants, particularly steroids in patients with Crohn's disease or ulcerative colitis, and then this particular organism becomes reactivated, and with the reactivation then can cause the disease in that particular organ, especially in the colon, where there's a large number of CMV that's been localized, and that's where the reactivation quite commonly occur, not only in the colon, but also the entire GIT in the esophagus also. So in our setting where with the ulcerative colitis and Crohn's disease, it's not necessarily the treatment that reactivated the CMV in colitis, but the chronic inflammation of the underlying inflammatory bowel disease. And then with this reactivation, especially with the steroids, that tends to promote the infection by down-regulating the monocyte and T lymphocyte activity. And we know that within the CMV virus, the immediate early genes transcription becomes reactivated. That suddenly reactivate the latent virus infected cells, and then the CMV tend to cause the pathogenic effects on the colon. So we see in these settings mostly it's actually the steroids more than the monoclonal antibodies, the biologics, but also our therapeutics like azathium that we use together with steroids tend to facilitate CMV from latency to more active disease. Next slide. So as I mentioned previously, the CMV has a lot of impact in terms of the prognosis and an outcome in patient with inflammatory bowel disease, not necessarily in a Crohn's disease, but particularly in patients with ulcerative colitis. Patients infected with CMV, especially with high viral load in the colon, they are high risk of being referred for surgical intervention like colectomy, and we know the outcome, which has got serious impact on the morbidity and mortality. So these are some of the things that can as you said, can reactivate a latent CMV. Even simple stress and immunosuppression, someone get the HIV infection, all this can reactivate the latent CMV viruses. Next slide, Prof. The immune modulated drugs have been found that they could actually these are the drugs that control the flare, but at the same time they can reactivate the virus within the gut. As we mentioned, the mucosal inflammation that is increased in patients with IBD, and the impairment in corticoid and suppressive efficacy is probably the reason why patient with the IBD with the reactive with the flare of the UC have got steroid resistance. In those patients, that you got to be very worried that if somebody is on steroids and is not responding with an acute severe ulcerative colitis, the first thing that one should think about is that there could be some concomitant CMV reactivation. And it was found that in those patients, they actually more than 20 times risk. This patient most likely has got CMV.
Modise, have we lost you?
Infection. I think these are not, most of them, as I mentioned, that they're asymptomatic, but those are symptomatic. Usually, those are immunocompromised. I think the next slide, Prof. Yeah.
Okay.
Features that you need to look for when you suspect somebody could CMV colitis in a setting of ulcerative colitis. It's recommended that when you do a biopsy for this patient, you need to take quite a few number of specimens in this patient, especially in the left-sided colon biopsies where mostly our UC patients present. You need to take at least around 11 biopsies, which I think that's probably what some of us are not really doing. I think that's worth mentioning. In somebody who's got Crohn's disease, you need, on the right side, you need at least more than 16 biopsies. It's quite a number of specimens. This helps you at least to achieve at least 80% probability of identified CMV infection in this patient. What do you see on endoscopy when you do colonoscopy for this patient? You will see several punch out lesions, and it's mentioned that it's very important that where you take biopsies, it's very important, as particularly you need to take on the edge and the base of the ulcer that you see on endoscopy. This is where most of the CMV positive cells are highly concentrated, and the specimen must be immediately fixed in a formalin or a paraffinized assay. What do you see on histology when you see this patient on the specimen? You'll see typical on what you call H&E stain, the inclusion bodies, the owl appearance, which are highly specific for CMV. And when you see them, In fact, that's mentioned that this is bad prognosis for patient. This patient is most likely to develop, to go under the knife for colectomy. The most important sensitive test that one also would do is the tissue PCR of the CMV. In fact, it's noted that this is a standard test for, we need to take that biopsy and do the tissue PCR. The immunohistochemistry that identify immediate early genes and early viral antigen is also a gold standard for diagnosis of CMV colitis. The peripheral blood for CMV viral is not really sensitive, especially for early CMV colitis. The international guidelines recommend immunohistochemistry and tissue viral load PCR to look at the quantitative PCR, which is much more sensitive though than immunohistochemistry, and it's more reliable and it's not observer dependent. There has been some studies where they look at the stool CMV DNA as an alternative to do biopsy, but it's been found that it's actually very low sensitive. Yeah. Next slide. So what's the treatment for these patients with CMV colitis? The antivirals like your ganciclovir, which inhibit your PL54, which is one of the the polymerase, CMV polymerase, that you inhibit the proliferation of CMV, that act as a chain terminator. The recommended treatment is IV ganciclovir 5 mg per kg BD for 5 to 10 days, then followed by the valganciclovir at 900 mg daily for the next 21 days. But for patients who are intolerant or they've got side effects or they are refractory to ganciclovir, one could also consider Foscarnet, but the problem with that is that you need to closely monitor the renal function as it has some irreversible renal damage. Most importantly, patients who are immunocompetent, there's no need basically for treatment, except in patients who are a bit older, they've got comorbid diseases like diabetes and chronic kidney disease. So the treatment for this patient, the duration in some cases, like in IBD, has been given for much longer time if you're not eradicating the infection. So what is the risk? What is the CMV risk in IBD? It's basically two factors that predispose one to CMV reactivation in inflammatory bowel disease. Mostly the corticosteroids use and thiopurines, and there is high risk of colectomy in the next 6 months in anybody who present with acute severe ulcerative colitis associated with high CMV. So CMV positive patients on immunosuppressants are also at risk of and organ reactivation. The concurrent CMV colitis worsens the prognosis of patients of active IBD with a major risk of rate of disease flare, toxic megacolon, and high rate of colectomy. Refractory IBD should be tested, as we mentioned previously, for CMV colitis, especially if not responding to immunosuppression. Mention that the prevalence in patients with steroid refractory acute colitis is quite high, at around 10 to 30%. And CMV colitis is an independent predictor of hospitalization and surgery, and it has poorer prognosis in IBD patients. The concurrent CMV increased risk of steroid refractoriness is increased, as we mentioned, 2 to 3-fold. With the exposure to thiopurines increases the risk much further for CMV reactivation. Next slide. These are the tests that we mentioned previously to test for CMV in patients with IBD, tissue immunohistochemistry, which got 97% specificity and 23% sensitivity, and the tissue PCR which is much more sensitive in patients with active CMV infection with IBD. As we mentioned, blood CMV viral load is not really, there's no cutoff level for blood CMV DNA to distinguish latent from active infections. But in patients with post-transplant, the cutoff is mentioned it's 4,000 to 10,000 per ml. Next slide.
I think let's just discuss a bit of CMV. So I think you've covered most of it. I think in our setting, really, it's the association between CMV and ulcerative colitis that's the most important. So every single patient who has acute severe ulcerative colitis must have a flexible sigmoidoscopy to look for the presence of CMV. If you don't treat the CMV, the steroids are not going to work. It makes patients steroid refractory. Okay, so for our particular setting in IBD, PP65, not necessary. Serum, PCR, etc., viral loads, not necessary. The tests to make the diagnosis of CMV colitis is the owl's eye inclusion bodies on a tissue biopsy and immunohistochemical staining, which is positive. PCR, yeah, it is useful, but it can also be positive without there actually being a true CMV colitis present. And then just in terms of treatment, yes, we use intravenous ganciclovir, but we don't use 21 days of valganciclovir. We'll give about a week of intravenous and then switch to oral valganciclovir for about a period of about 2 weeks in total. Just importantly, in IBD, you do not have to discontinue immunosuppressants when patients have a CMV colitis. You carry on as is. Right, there's someone in the chat. I'm just going to see if I can open it up. To you, Modise. Thanks for the fascinating talk. In patients with concurrent CMV colitis and acute flare of UC. Oh, sorry, I think I've just answered that question. No, you don't need to withhold immunosuppressants pending treatment for CMV. Any other questions on CMV?
Sorry, Jill, it's Nash here. Thanks
Hi,
for
Nash.
Modise and you. Maybe to the fellows explain the issue of whether there's invasive CMV colitis or whether it's just there as a bystander and what you do about that, particularly in the context of IBD flare. Thanks.
Yeah, absolutely. This is a hotly debated issue. Is if you find CMV on those biopsies, is it actually a CMV disease or are they innocent bystanders? Because remember, this infection is almost ubiquitous. Okay. Prevalence rates 70 to 100% in regions or across Africa. So how would we make this call? Well, essentially, if there are a lot of inclusion bodies and there are many cells that stain positive with immunohistochemistry, I think you're pretty sure that you're dealing with an active disease. And in any case, one would want to actually treat it, just in case it's playing a role in making patients steroid refractory. It is a little bit of a problem when you find that one little CMV inclusion body or that one little cell staining with immunohistochemistry. And I think, that is a bit debatable. In our practice, if we find CMV in patients with severe ulcerative colitis, they get treated, which whether that's right or wrong in every case, I'm not sure, but we don't like to take a chance because of the high risk of these patients having a colectomy.
Professor Gert van der Merwe again.
Oh, hi.
May I ask a question again?
Of course,
from
please.
the ignorant surgeon side. So again in colorectal discussions, the point is frequently made that if there is in the setting of acute severe colitis, also ulcerative colitis, if we do find a CMV, we should hang on with surgery.
Yeah, look, you wouldn't want to hang on any more longer than you would with acute severe ulcerative colitis. Patients mustn't go past 10 days, regardless. Okay. But so that wouldn't change. But I agree that one would want to probably go a little bit longer than you would in the patient who is CMV negative, in the hope that you should put things around, but probably not a day or two more than you would make that call anyway.
Okay, all right. Thanks, Prof.
Okay, so let's move on. I think we're almost going to run out of time, so let's hang on. What's going on here? moving on. Let's just finish up with amoebiasis.
Yes, amoebiasis is one of the second leading cause of death due to protozoal infection after malaria. In fact, almost 50 million people are infected in the developing world, including Africa, India, and South America. The risks are obviously mostly it's a contaminated water supply and the poor sanitation, poor infrastructure. And it's not everybody who gets the disease because of the our genetics has got determinants in terms of pathogenesis, which interacts with our intestinal flora and the organism. Next slide, Prof. The site commonly involved in patients with amoebiasis, it's cecum, ascending colon, and rectosigmoid colon. As I mentioned, in 90% of patients, they're basically symptomatic. It's only 10% of patients who are symptomatic.
I moved on. Is this where you want to be? Sorry, Modise. Is it the slide that you're on, or is it the next slide?
Yes, that's one.
Still this one, okay.
This is the one.
Yeah.
And as I mentioned, it's not everybody who's got amoeba symptomatic. These are, and because most of them are not, it's not pathogenic, but there are certain determinants that factors that determines whether amoeba will cause disease in your body. It's basically the amoeba itself, the virulence of the strain, and our own immune system, the males and female, and the age of the patient, and also the microbiota, the associated bacteria in the GIT tract also. Next slide. For those who are symptomatic, it's only a small percentage, which is 10% patient presenting with amoebic colitis. These are patients who present with severe diarrhea, bloody stools, fever, and abdominal pain. And later on, when it becomes more worse, this patient can develop invasive amoebiasis with dissemination of this bacteria, of this parasite everywhere, liver, the lung, the brain, or sometimes in the wall of the ascending colon, there's a granulomatous mass that sits there, the amoeboma. As I mentioned, infections can also spread all over, but particularly what is more common extraintestinal, it's a liver abscess, amoebic liver abscess. Interestingly, that it's much more commoner in males than female, in people around 18 to 50 years. We don't know why, particularly in males and female. It could be related to hormonal factors or iron deficiency. So women could be probably more protected. Yes. The pathogenesis, we mentioned that is mostly from the cysts that consume the from the contaminated water and food. In the intestine, it moves from the cyst that you consume become encysted in the bowel, and with the trophozoites released, and that starts to burrow into the intestine. On the amoebic cell, we've got the receptor, the gall nerve lectin, that interacts with the mucin on the wall of the intestine. That is that interaction that really leads to the invasion of the amoebic trophozoite into the portal venous system to go to the liver and the other organs. But safe to mention that once the trophozoite gets released outside through the feces, it rapidly dies. But the cyst, that's the one that we get reinfected, survives much more longer than weeks. Next slide, please. As I mentioned, not every strain of amoeba also causes amoebiasis disease. I just wanted on this slide, I wanted to show some of the features that one can see on colonoscopy, and just diagnostic representation of the type of ulcer that it's mentioned in patients with amoeba. When you look at the central picture here, you can see multiple. They call. I mean, if you look at, let me first look at this on the type of lesion, the drawing that they try to show us what is meant by flask-shaped ulcers, where this trophozoite burrows into the mucosa. The type of the ulcer that it leaves behind, that's what they mention as multiple flask ulcers. So in specimen, you can see those multiple ulcers also here. Next slide, Prof.
Sorry. There we go.
And this histopathology, what you, after you've done a biopsy, you will see on the biopsy the amoebic trophozoite on the biopsy, or even when you send fluid stool for culture, you see the intestinal fluid will also grow the amoeba. The serum anti-amoeba histolytic antibody examined titers, if there are more than the titers of 1 to more than 120 positive, most likely confirms the diagnosis. Interestingly, in patients with extraintestinal, like patients with the liver abscess, amoebic liver abscess, this patient might not have any, the stool might not show any cysts that we able to be detected and to confirm the amoebic colitis. In terms of treatment, as we mentioned, 90% of patients are not symptomatic. There's no need for treatment, basically. But for those who are symptomatic, present with fulminant or invasive colitis, a 10-day course of metronidazole or oral paromomycin should be given in this patient. But for those patients with fulminant amoebic colitis, because of concomitant risk of bacterial translocation, over and above the metronidazole, the antibiotic, broad-spectrum antibiotic cover must also be included in your treatment on these patients. Next slide.
Yeah, hang on. Okay. All right. So just before we go there, any questions about amoebic colitis? I see Cecilia asked if there can be features of chronicity if it's been around for a long time. Absolutely, there can be. You said that you wouldn't treat an asymptomatic individual. I don't think that's quite correct. I think you need to treat all Entamoeba histolyticals. It's different if it's an Entamoeba, one of the other Entamoeba species where they are not necessarily pathogenic, such as this bar. Paromomycin, yes, absolutely. And that would be what you would use to treat an asymptomatic patient. Okay. Unfortunately, we don't have it available here in South Africa, so that is quite unfortunate. And just the last thing to mention is in a person who has an isolated proctitis and you pick up Entamoeba histolytica on your biopsies or in stool, then you need to take a history. Could this be a sexually transmitted disease? I've seen quite a few of sexually transmitted Entamoeba histolyticas. Any questions other than me in the chat here? No. Anybody want to ask anything about this? We're actually running out of time, so I think we're probably going to have to stop there. Karen, you mentioned that Monique from Janssen wanted to present something to the group.
Sorry to jut in there. We
Yes.
just had a chat offline with Monique, and she says she's happy to defer it because of time.
Okay. Okay, fantastic. Well, anyway, then I think I'd just like to thank Modise for his great talk there. I think he put a lot of work in. He tried to fit in a lot more other infections that we decided not to do in the interest of time, but of course he's learned all about them now, which is great. So just to say, there's something in the chat. What's that say? Oh, thanks all. Okay. yeah, so just to end off by saying thank you to all of you for joining today, and thanks very much for Modise for his presentation. And of course, thanks to ECHO University of New Mexico and ECHO India for the support. And of course, feedback forms are available in the chat. The recordings are available on the website. And the next presentation on the 31st of October will be Cecilia Kocher on colorectal cancer with Adam Boutal moderating. Okay, so thanks everybody and have a good evening. Yeah, and if there are no more questions, I think we'll close up there. Mash, you happy?
Thanks, Prof. Thank you so much.
Yes, thank you so much. Thank you.
Okay, pleasure. Bye.
Thanks, Prof. Bye.
Thank you. Bye-bye.